Hello, my name is Yvonne and I work within the field of diabetes. According to Diabetes UK, most health experts agree that the United Kingdom is facing a huge increase in the number of people with diabetes. Since 1996, the number of people diagnosed with diabetes has increased from 1.4 million to 2.9 million. By 2025, it is estimated that 5 million people will have the condition. Most of these cases will be type 2 diabetes because of our ageing population and rapidly rising numbers of overweight and obese people. The figures are alarming and confirm that diabetes is one of the biggest health challenges facing the UK today. If we are to curb this growing health crisis and see a reduction in the number of people dying from diabetes and its complications, we need to increase awareness of the risks, bring about wholesale changes in lifestyle, improve self-management among people with diabetes, and improve access to integrated diabetes care services. Type 2 diabetes mellitus is associated with an increased risk for both micro and macrovascular complications, and cardiovascular disease, otherwise known as CVD, are the most common causes of death in these patients, accounting for almost 70% of them. Macrovascular disease is a disease of any large macro blood vessels in the body. It is a disease of the large blood vessels, including the coronary arteries, the aorta, and the sizable arteries in the brain and in the limbs. This sometimes occurs when a person has had diabetes for a long time. Fat and blood clots build up in the large blood vessels and stick to the vessel walls. 3 common macrovascular diseases are coronary disease in the heart, cerebral vascular disease in the brain, and peripheral vascular disease in the limbs. Macrovascular disease, otherwise known as macroangiopathy, refers to atherosclerosis. Atherosclerosis is a form of arteriosclerosis, which means thickening and hardening of arterial walls, characterised by plaque deposits of lipids, fibrous connective tissue, calcium and other blood substances. Atherosclerosis by definition affects only medium and large arteries. Macrovascular disease is associated with the development of coronary artery disease, peripheral vascular disease, brain attack, which otherwise known as stroke, and increased risk of infection. Type 2 diabetes is more closely associated with macrovascular disease than type 1 diabetes. Peripheral vascular disease and increased risk of infection have important implications in the care of the acutely ill patient. Given the high prevalence of the condition and the expected global increase in the prevalence of type 2 diabetes, a case is made for prevention of these serious complications in order to reduce the individual morbidity and the economic burden on society. Macrovascular disease in patients with type 2 diabetes may be prevented, and important risk factors for CVD and diabetes, such as dyslipidemia, hypoglycemia, hypertension, smoking, familial premature coronary heart disease, and some non-classical risk factors such as hyperinsulinemia, insulin resistance, endothelial dysfunction, and inflammation needs to be focused on closely. Present knowledge indicates that most patients with type 2 diabetes either have manifest CVD or have high risk for future cardiovascular events. Men with diabetes have a 2 to 4-fold increase, and women with diabetes have a 3 to 5-fold increased risk for cardiovascular death compared with non-diabetic individuals. Care of patients with type 2 diabetes should include yearly risk assessment by the use of published risk equations or risk charts. On the background of this assessment, an individual risk-reducing strategy should be tailored to each patient's needs, including the treatment of hypoglycemia, hypertension and dyslipidemia, together with the use of aspirin and ACE inhibitors. Such measures can reduce the risk of cardiovascular events in patients with type 2 diabetes. There are, as mentioned, many risk factors to be addressed in the prevention of macrovascular disease. However, the risk that I'm focusing on today is high cholesterol. Why is high cholesterol bad? Cholesterol is a natural substance found in our diet and made by our liver. It is the key for many functions throughout our body, yet high levels of cholesterol are linked with atherosclerotic vascular disease, as well as stroke, heart attacks, heart disease, and peripheral vascular disease, arteries of the legs. Over decades, high blood cholesterol levels may result in damage and narrowing of arteries that supply the heart, brain and other organs. In time, the poor blood flow may damage those organs and cause sudden heart attacks and strokes. Well, what are the good and bad cholesterols? Cholesterol travels in the body in little packets of fat or droplets known as lipoprotein particles. These fat droplets, which begin in the liver, contain cholesterol or triglycerides. The other major fat in the blood. The 2 chief lipoprotein particles of fat are low-density lipoprotein, otherwise known as LDL, and high-density lipoprotein, otherwise known as HDL, each of which carries cholesterol. LDL cholesterol is the bad cholesterol. HDL is the good cholesterol. LDL carries most of the cholesterol in the blood and can stay in blood vessels over time and lead to atherosclerosis, fatty deposits in the blood vessels. Studies have shown that high levels of LDL cholesterol are linked to a greater risk for stroke and heart attacks. HDL particles help remove cholesterol from the arteries and helps return cholesterol to the liver. Studies have shown that high HDL cholesterol levels protect you from a heart attack. HDL also lowers your risk of a first heart attack or a second one. However, LDL cholesterol is the bad form of cholesterol in the blood. Triglycerides are another type of fat in the blood. If you have raised cholesterol and raised triglycerides, you have an increased risk of CVD. What are the patterns of lipid abnormalities? Well, according to the Centres of Disease Control, 97% of adults with diabetes have one or more lipid abnormality. The central characteristic of dyslipidemia in patients with type 2 diabetes is an elevated triglyceride level, particularly triglyceride-rich VLDL levels and decreased HDL cholesterol levels. In diabetic patients, the concentration of LDL cholesterol is usually not significantly different from that seen in non-diabetic individuals. However, patients with type 2 diabetes typically have a preponderance of smaller, denser, oxidized LDL particles, which may increase atherogenicity, even if the absolute concentration of LDL cholesterol is not elevated. This lipid triad, referred to as atherogenic dyslipidemia, is usually present in patients with premature coronary artery disease. When this characteristic lipid profile is seen in type 2 diabetes, it is referred to as diabetic dyslipidemia and confers a risk of CVD that equals or exceeds that of a high-risk LDL cholesterol concentration of greater than 3 millimoles per litre. According to the American Diabetes Association, the presence of increased triglyceride and decreased HDL levels is the best predictor of CVD in patients with type 2 diabetes. Other predictive factors include a history of cigarette smoking and hypertension. The evidence regarding the predictive value of elevated LDL cholesterol is still accumulating. Most recently, results of the Strong Heart study indicate that LDL cholesterol is an independent predictor of CVD in patients with diabetes, along with age, albuminuria, fibrinogen, HDL cholesterol, and percent body fat. A clustering of risk factors which has been labelled the metabolic syndrome occurs commonly in type 2 diabetes and simultaneously affects the development of CVD and diabetes. Insulin resistance is present, usually in association with features such as hypertension, elevated triglycerides, low HDL cholesterol, increased small dense LDL particles, endothelial dysfunction, a prothrombotic state, and abdominal or visceral obesity. Often these risk factors may be exacerbated by lifestyle choices, such as a high-fat diet, a sedentary lifestyle, and smoking. The central feature of the metabolic syndrome is insulin resistance, defined as the impaired ability of insulin to lower blood glucose. Insulin resistance is common among people with impaired glucose tolerance and characteristically precedes the onset of type 2 diabetes. Recently, the National Cholesterol Education Programme identified the metabolic syndrome as a secondary target of therapy beyond LDL lowering. Intensive treatment of dyslipidemia, high blood pressure and hypoglycemia is now considered essential in the treatment of diabetes, as has been shown by numerous reports from the UK Prospective Diabetes Study. A recent study found that lipid values, hypertension and other CVD risk factors were even more strongly associated with coronary disease than glucose status per se in patients with diabetes. In addition to physical inactivity and advance in age, obesity and particularly abdominal or visceral obesity contribute to insulin resistance and hyperinsulinemia. In its own right, obesity is associated with atherogenic changes in lipids as well as with hypertension. How do we manage dyslipidemia? Well, aggressive screening and management of lipid abnormalities is essential for patients with type 2 diabetes in order to slow the progression of atherosclerotic disease. Levels of LDL, HDL, total cholesterol and triglycerides should be measured when diabetes is first diagnosed. The American Diabetes Association recommends that screening be repeated yearly in most adult patients because frequent changes in glycemic control may affect lipoprotein levels. In some patients whose levels remain in the low risk category, assessment may be repeated every 2 years. Increasing the approach to diabetes management is predicted on the principle that diabetes itself is a CVD risk. Consequently, there is less distinction between primary prevention of CVD and secondary prevention of people with type 2 diabetes. Because patients with diabetes have a higher case fertility rate and are more likely to die than non-diabetic patients before they reach the hospital, a preventative strategy based solely on secondary prevention is not likely to be sufficient as a means of preserving lives. Therefore, patients with diabetes but no established CVD should be treated as aggressively as non-diabetic patients with established CVD. What should my cholesterol be? Know your numbers. Your doctor may screen total cholesterol and/or HDL cholesterol, non-fasting or a fasting full lipid profile in which the triglycerides and LDL cholesterol are measured. You should be aiming for your total cholesterol level to be below 4 millimoles per litre. LDL level should be less than 2 millimoles per litre. HDL level should be 1 millimole per litre or above in men and 1.2 millimoles per litre or above in women. Triglyceride levels should ideally be 1.7 millimoles per litre or less. If you do not know your lipid levels, ask your healthcare team to arrange a simple blood test for you. Many doctors support screening all men and women 20 years older and children from families with a high risk of heart disease. People with healthy levels should be rechecked every 5 years. But as mentioned, lipids are generally checked annually in people with diabetes. What makes cholesterol high or low? Well, you have family history. High cholesterol often runs in families. Many patients will remain high despite doing things right. Young women have lower LDL cholesterol and higher HDL cholesterol levels than men. After menopause, women's risks are the same as men's. Then you have diet. Diet should contain less than 30% calories from fat, less than 8% from saturated fat, and enriched in marine or plant omega-3 fatty acids. Avoid high saturated fats like dairy fats, ice cream, butter and palm or coconut oils. Limit high cholesterol foods like eggs and organ meats, liver. Eat higher fibre foods, fruit and vegetables. Eat more fish, skinless chicken breasts. Avoid fried foods and frying which soaks up the fat. Choose low-fat and non-fat dairy products. Avoid hard margarines which have trans fatty acids and try to use products made from plants instead. And of course you have weight. Weight is a factor. Lose weight if overweight. Excess weight is linked with high cholesterol, low HDL cholesterol, high triglycerides, diabetes and high risk of heart disease. Exercise. Even mild regular exercise has been shown to raise HDL cholesterol levels and lower triglycerides. This works even better when a weight loss program is part of the plan. And quit smoking. Smoking clearly increases your risk of heart attack and stroke. It also lowers your HDL cholesterol. Alcohol, well, 1 or 2 drinks daily has been shown to increase HDL cholesterol, but too much alcohol damages other organs, so it's not a good way to prevent heart disease. Should you be placed on medication for your cholesterol? Well, medications are reserved for people at high risk for heart disease or those with known vascular disease, stroke, heart attack, peripheral vascular disease. There is proof that middle-aged and older men and women with vascular disease or diabetes are helped from a drug class known as the statins, no matter what their cholesterol levels are. Patients with diabetes are at a greater risk of vascular disease and need strong treatment. Most often, patients without vascular disease who have high cholesterol with or without other risk factors should try diet, exercise and weight loss if overweight prior to using medications. Those with high cholesterol or high triglycerides, overweight, diabetes and any vascular disease should see a nutritionist before starting medications. If you have no vascular disease, your doctor may start medications right away. Even so, lifestyle changes are still very vital in lowering your risk. Medications for cholesterol are most often long-term medications. They have to be taken every day, often for the rest of your life. Drugs that are most often prescribed, as mentioned, are the statins. Statins help the liver remove LDL cholesterol and reduce production of cholesterol. These drugs, most often, do not have side effects, but may interact with other drugs you take in. Make sure you ask your doctor about how statins will work with other drugs and herbal products you would take in. Things such as grapefruit juice should be avoided with certain statins since it blocks the metabolism. Rarely these drugs can cause liver or muscle damage, but if you do start to notice muscle aches all over your body or weakness while taking these drugs, stop them and call your doctor. High cholesterol and lipid levels can significantly increase the person's risk of developing chest pain, heart attack and stroke. Fortunately, a number of effective treatment options are available. Lipid levels can almost always be lowered with a combination of diet, weight loss, exercise and medications. As lipid levels fall, so does the risk of developing coronary heart disease, as well as the risk of suffering a heart attack. It is not too late if CHD is already present. lipid-lowering treatment can be life-saving. Of these approaches, in certain cases, a clinician will recommend a trial of lifestyle changes before recommending a medication. Lifestyle changes. All patients with high LDL cholesterol should try to make some changes in their day-to-day habits by reducing total and unsaturated saturated fat in the diet, losing weight, if overweight or obese as mentioned, and performing aerobic exercise. The benefits of such lifestyle modifications may be evident within 6 to 12 months. However, the success of lipid lowering with lifestyle modification varies widely, and clinicians may elect to begin drug therapy before this time period is over. Sticking with treatment. The treatment of high cholesterol and or triglycerides is a lifelong process. Although medications can rapidly lower your levels, it often takes 6 to 12 months before the effects of lifestyle are noticeable. Once you have an effective treatment plan and you begin to see results, it's important to stick with the plan. Stopping treatment usually allows lipid levels to rise again. Most people who stop treatment do so because of side effects. However, there are a wide variety of medications available today, which should be possible and make it possible for most people to find an option that works for them. Talk with a healthcare provider if a specific medication is not working. He or she can recommend alternatives that are compatible with your lifestyle and beliefs. Because type 2 diabetes can be considered a cardiovascular disease in its own right, current American Diabetes Association and the National Cholesterol Education Programme guidelines recommend aggressive treatment of dyslipidemia in people with diabetes, particularly for elevated LDL cholesterol levels. Use of appropriate treatment as determined by the pattern of lipid abnormalities can substantially reduce the risk of macrovascular disease. Institution of tight glycemic control will be beneficial to most patients, but the majority of people with diabetes will also require diet therapy, weight reduction when necessary, and intensive lipid-lowering therapy, which commonly involves one of the statins as mentioned, or fibric acid derivatives. Prevention of cardiovascular complications of diabetes must be considered a national public health goal in light of the increasing prevalence of the disease and the high frequency and seriousness of its complications. Thank you.